right, well, welcome everyone. This is the June meeting for the local alcohol and drug planning committee. My name is Eric Geyer. I chair this meeting. Our next agenda item is the quarterly update on utilization from our CCOs.
Julia, you want to go first?
Sure. I think also in this process, it would be helpful to know, like, just so we're comparing apples to apples, as Jeff and I learn, what data we each have, we'll try to align more and more so that you get the whole picture. So what we're going to be looking at is now that claims have come in for quarter one, we're looking at everyone who accessed services from January, February, March, April. May might have a little bit inaccurate look just because it's close to that claims lag for 2021, and then we'll compare it to previous years. But Eric, did you want me to just focus on substance use services and not mental health?
I actually think that the more, as you do this, our task is really substance use oriented, but for many of our folks, they're really dealing with both at the same time, and sometimes the mental health data might be helpful. So
yeah. And just a note on that, when you think about claims, when someone receives a service, the provider has to bill to a primary diagnosis. So someone could definitely be dealing with multiple, co-occurring diagnoses, but they'll be coming in primarily for either a mental health issue or substance use. Our system, and I'm not talking about JCC, I'm just talking about the behavioral health system in general, is very bifurcated, and it silos it out. And ultimately, we know that it's a whole person, and those issues kind of equally play a part, but it's still very much siloed, unfortunately. This is just a snapshot of our membership. In March, it was at 55,972. Right now, it's at 57,451. That was as of the 15th. This is a reminder of our levels of care. So we have residential and detox through our our anchor providers, which is ARC and On Track. We have psychiatric day treatment for youth through Family Solutions. We have over 10 large clinic providers, 50 plus independent practitioners. We also have integrated behavioral health consultants built into primary care. And then we have a variety of supportive housing beds. I was really interested actually in the Oxford House presentation, because when I was in Columbia County, we went over to Washington and toured an Oxford House and met with folks and learned a lot about that. And so I'm really curious into how we can support Oxford House growing in this area also. So this is a look at mental health in the red line and substance use in the green line, percentages. So of our total 57,000 members, for example, in 2021, 19.7% of all of those members are accessing mental health services, and 7.4% are accessing substance use services in both specialty behavioral health and primary care settings. So what that means is, this could be like in a physical health care setting or like an actual treatment center. This is both settings. So you can see that year over year, typically, except for COVID, there's been an increase in folks accessing mental health services, but not so much in substance use services. 2019 was probably the biggest peak in that. And then, again, COVID actually took more of a hit on folks accessing mental health services than it did on folks accessing substance use services. But still, there was definitely a dip there. This is looking at how mental health services are accessed differently in specialty behavioral health setting versus primary care. So primary care setting is in this green line, and specialty behavioral health clinics is in the red. So this just means that there's far more folks accessing mental health services in settings that are designed to treat mental health than are in physical health or primary care. But the reason why we want to change that is because we don't want there to be any wrong door. So whether it's primary care, physical health, folks should be able to get the treatment that they need, get connected that way. Same with substance use. Folks are accessing substance use services more than normal, more than typical in primary care or physical health settings, and a little bit less in specialty behavioral health settings. Okay, so this is just looking at this year so far. In 2021, it's been pretty static. We had a slightly higher start to the year in January. 20% of folks accessing mental health services, 7.6% of all of our members accessing substance use. It's gone down a little bit for both mental health and substance use utilization. It'll be interesting to see what happens with vaccinations, what happens with more in-person visits, those kinds of things. This is kind of a snapshot of where most of our members are landing for mental health services. It's Columbia Care, then Options, Kairos, La Clinica, as you can see in volume. So this is kind of volume per provider for mental health. This is volume per provider for substance use. ARC, Allied, Phoenix, On Track, La Clinica, and so forth. So this is some information regarding age. So difference in age over the years for folks accessing mental health. But remember that 2021, which is in the red line, we're only a couple months in for utilization, looking at utilization. And the main trend that I'll point out here is just across the board, mental health is increasing at a rate that will surpass other years. And the same can be said for substance use utilization, that it's on that track to surpass. This looks at mental health utilization by race. The orange bar in the middle is 2020. The yellow top bar is 2019, which you can remember was kind of highest utilization. And then the red is where we're at so far for 2021, considering that we're only a fourth of the year. There's a lot in the other category and not provided, and we don't have any good data on what that means. Really, it's across the board kind of an issue when collecting data on race. Substance use utilization by race. Again, 2019 is in the yellow, 2020 in the orange, red is 2021. So of all the members, again, how to read this is of all the members accessing substance use services, for example, in the first, I'll just use the first column as an example. In 2019, 8% of those were American Indian or Alaska Native. And then it's decreased. Okay, so average length of stay in residential last year was 36 days. Average length of stay this year is trending at 29 days right now. We know the more clean time, the better. So we hope to see a slightly longer average length of stay there. Also, this is deceiving. This looks deceiving. These numbers of 97 visits and 89 members in residential thus far is basically, again, that's only a fourth of the year. And for the whole year it was 307 visits. So it is on track to surpass that this year in residential stays based on the fact that we're only at a fourth of the year. And this just shows the difference per provider. So for On Track, our red line, That's how many members that they've admitted into residential. And as you can see, this being only a fourth of the year, both providers are on a path of going to be serving more folks in residential this year than in last year. This is interesting. It's member visit ratio per setting for detox. So if you look over to the left first, for ARC serving, providing detox in their setting, it's an average of 1 member per 1 visit. But in the ER, it's an average of someone going there twice. So 1 person on average goes there multiple times. And in inpatient, 1 person on average goes there 5 times. So this just kind of shows that ARC looks like the most effective setting for probably providing a little bit stronger discharge and follow-up and transition support for folks to reduce that recidivism. Again, these numbers here are definitely on track to surpass what they were in 2020 based on it being only a fourth of the year. And you can see ARC is in blue, the green line is inpatient, and the red line is ER. And that inpatient line, again, is deceiving because it's members served, but not necessarily how many times they go back. And we don't want folks going back that many times. Okay, last slide is emergency room utilization. This is rate per members because our membership changes every month. So we do it in rate form so that you can look at a trend over time. So the highest year of emergency room visits by folks who had folks who were suffering from a mental health diagnosis in red, that's the red line, and folks who were suffering from a substance use diagnosis in green. So the highest year of utilization in the ER was in 2017. It decreased drastically until 2019, continued decreasing in 2020, and we have seen an uptick with folks who have mental health diagnoses, but continue to see it kind of stay semi-stable, a little bit of a decrease with substance use.
What I'm going to show you is, a pretty pared down version. It's not unlike the data that I presented last time in terms of the categories. We did add a couple of pieces of data based on some of the feedback and questions from the group last time in regards to what percentage of folks showing up in the ED are already engaged in substance use disorder treatment, and what percentage are engaged and assigned to a PCP who are showing up at the ED. So we'll talk a little bit about that. Then I'll just quickly show you a side-by-side between last quarter and this quarter. So this is for quarter 1, January, February, March of 2021. The all care membership just under 16,000. First category there is the number of folks in outpatient treatment at 323. The next is the number of folks who made use of detox. This is all claims-based data, so this would be at least 1 encounter. And the detox may be local or it may be regional. So I just wanted to mention that. And that's 14 folks there. Number of folks in rehabilitation, otherwise known as inpatient residential treatments, would be 41. And again, to clarify, that may be local or it may be regional. We also contract with about a dozen inpatient residential facilities throughout the state. So that's at 41. And then we go to the hospital visits. The number of folks who were admitted inpatient at the hospital where their primary diagnosis on the claim was substance use disorder related was 9. And as I said last time, if we were to say the secondary or tertiary diagnosis was SUD related, that number would jump exponentially, right? So that would be folks who come in for a broken arm or a fall or a motor vehicle accident, where the secondary or tertiary diagnosis would be, alcohol intoxication or other stimulant abuse, uncomplicated, etc. But for the ones with the primary SUD diagnosis, that's 9. And then for the ED visits, again, where the primary diagnosis is substance use disorder, that is 71. And that number would also grow if we sort of opened that up to secondary and tertiary diagnoses. And then of those folks who showed up at the ED, the percentage of those 71 folks who were already engaged with a substance use disorder provider would be 23%. And that's based on at least one substance use disorder claim. And then the percentage of ED patients engaged with assigned PCP in that quarter who showed up at the ED, that would be 13%. And again, this information is, pretty pared down. If the group would like to see any more information from All Care, I'd be happy to provide that. I just thought sort of bite size might be good for the group. And of course, our membership is fractional compared to JCC's, but nonetheless, if there's something that you'd like to see, I certainly would like to provide that to you. And this is quarter by quarter. So the blue was the last set of data that I presented quarter 4 of last year, and then the red or orange, if you will, is quarter 1 of this year. You can see in terms of number of folks engaged in outpatient treatment and number of folks in inpatient residential and ED visits all went up, while those of detox and the inpatient admits decreased a little bit for this quarter of 2021. Any questions about any of that?
Just a comment, Jeffrey, that I really appreciate. It is easy to get my head around. This is bite size. It's very helpful. And especially when you put it into the context of quarter by quarter. So over time, we might be able to identify some trends or see how things are going, or maybe identify areas that we need to try and expand capacity. And I know this group's probably rolling their eyes when I say expand capacity, because everybody's trying so hard to build workforce. But, those are both things that we have to look at, I think, as a community. So it is helpful in that.
Sure.
Hey guys, it's Amanda, and I have a question. I'm just wondering, with the push to get naloxone out there for substance use, I'm just wondering, have we done any research on the reduction of ED visits with the distribution of naloxone? And I'm wondering too, do we have any data on whether people are visiting the emergency room or primary care after an overdose with the induction of naloxone? Does that make sense?
Sure. Thanks, Amanda, for that question. And I'll just answer the best I can and then turn it over to Julia. But what I notice, and anybody in the group here can correct me if I'm wrong, but I'm in the Epic records every day. And what I notice is that folks who are brought in for overdoses have also been given naloxone in the field in some capacity, whether it's by a bystander or EMS or something of that nature. So it appears that when emergency services are called, folks who have been given naloxone are brought into the hospital, I guess for medical clearance or just to check them out to make sure that they're okay. So I would say, 9 times out of 10, folks have been given naloxone in the field, and that's indicated in the hospital notes. So I just wanted to kind of put that piece out there. That would be a data set that we would have to kind of go in and pick through a little bit more carefully. I don't think it's impossible, but that would be another level that we'd have to kind of look into. In terms of your second question, it's a really good question. The follow-up care, anytime, this is just, I'm speaking for All Care's process on this. Anytime one of our members does show up in the ED with an overdose, we are referring that person for follow-up to either a community provider that the person's already involved in, or I will send that referral to Options for Southern Oregon for follow-up with that member. So they're oftentimes receiving behavioral health follow-up, and in terms of medical follow-up, they would be receiving that if the hospital arranges that. And typically that only happens, as I see it, if someone is actually admitted to the hospital, not so much if they're just there for an ED visit. Again, that's a set of data that we could also look at, but it would take some picking through. Thank you.
Yeah, and I don't have anything different to add. I mean, I think that's the point, is that there's, claims data when it comes through is super high level. And so these type of details would require a lot of scrubbing and looking into, you have the year over year general emergency room utilization data, but in terms of factors that impact those visits, that's a whole nother layer.
So it's Amanda again, and my connectivity is not stable. So I lost a little bit of the responses, and I just thought that I would pose the question to the group of whether or not there's like cross analysis between the county, like Jackson and Josephine counties, and their naloxone and harm reduction model and prevention models with like the state CCO coverage for ED visits. For example, like if the county is handing out naloxone and clean needles at such and such rate, and then we're having ED responses, emergency responses, and how that correlates to the new Oregon regulations for possession charges. I'm just wondering, have we looked at all of that as LADPC? Does that make sense? It's kind of like a really broad question, but looking at the data, I just don't know if it reflects what's really going on in our community, is all I'm saying.
I just had one quick comment on that. I think, and again, I am certainly not a math geek by any stretch, which is why I'm in the field that I'm in. But what I would say is seeking correlations between county distribution of naloxone and how that plays out at the hospital level is going to be really, really difficult. For one reason is the county is not the only place distributing naloxone. Right. So, I mean, there are other entities that are distributing the naloxone. And so I think that would be a tough correlation to make. But I would be open to that discussion for sure.
Yeah, I agree. You always have to identify how the data might not be a complete picture. But just in terms of commenting on our goal with sharing data, it's for these kinds of questions. I think we can turn this into, rather than just a numbers report out, if there's a particular focus that the group wants to propose for a certain quarter or by the end of the year or whatever, that Jeff and I can work on, and or providers in the room as well, in terms of looking at their own data to share. But if there was a project that we wanted to focus on in terms of how, what we want to look for with utilization or the correlation there, that would be something. This is an example of it. I'm not saying that that's what we're committing to, but this is the type of thing that we want to do as we grow this data sharing goal and activity. Is there a scope we want to narrow down, as opposed to just straight across the board utilization of services? I think that would be an excellent use of data analysis time. And there could always be some things proposed. Jeff and I, and maybe the large providers in the room, could look and even see what was possible with being able to, accept or refine the scope of a data proposal, and then, set a period of time that we want to be tracking that for. So I'll just put that out there and turn it back over to Eric.
Sarah, yeah, that's a tremendous offer, Julia. Thank you. Yeah.
Yeah, it is. And maybe just to kind of follow up on that, is there a system, or could we create a system so that when people come into the hospital, especially the ED for an overdose, knowing that they are very likely to overdose again, how do we link them? How do we make sure that they get naloxone?
So just so that I'm making sure I'm following you, is there you're asking if there's a way in current claims to know if they were not connected to a naloxone resource?
Well, mostly I'm just wondering if they end up with it after they land there for an overdose. But it seems like there's challenges sequentially, and right, with when did they go to the ED and what was the primary diagnosis, and then like Oregon Health Authority has the opioid data dashboard, but it's limited in the conclusions you can draw from it for a lot of reasons. So I just think that if we're collecting data on people nearly losing their lives, that it would be a good use of that data to link those people with naloxone. But, in a sense, easier said than done, right? Like there needs to be a system to do that, but that could be a really good use of data if someone landed in the ED, and then is there a naloxone claim after that, or were they linked with a community organization for which there wouldn't be a claim?
Right.
So this is Amanda again, and so I'm sorry I opened a can of worms, because now I'm recognizing that it would be very difficult to. So my initial question was about the data and about how it reflects what's going on in our county, because now if you get caught with under a gram or whatever of meth or heroin or any other controlled substance, there are lesser charges and lesser consequences than there used to be 10 years ago, 5 years ago. And so data might have been different 5 years ago with OHP or people who didn't have private insurance. And so what I was thinking was, with the push with naloxone specifically, just because fentanyl and heroin is so prevalent in Jackson and Josephine County in Southern Oregon, well, all Oregon really, I was just wondering if we're noticing an underutilization of treatment services because there's less, penalty, and because there's more, I guess I would say, life-saving prevention modalities with naloxone. If people are just stabbing themselves with some naloxone and then not accessing treatment, I was just kind of I was just posing it to the group, like how we're kind of cross-referencing all the different interventions that our area is using. But it's so big. It's like such a big question that I really don't think that there's an answer to it.
So Amanda, this is Mike O'Malley. First of all, thank you for bringing it up. I mean, these are the kinds of problems we'd like to have in terms of understanding the data. I would just point out that we've been only distributing naloxone for a few years, and it's definitely have a positive impact on the population. But the population is such a high utilizer, and there's so much potential morbidity, mortality, that it's worth this kind of discussion. It seems to me, I don't even know if, like, when somebody presents at the ER, if there's a box in the electronic record where you check to see whether they've ever had naloxone, or whether they're offered that resource when they leave. That's the kind of information we need to have to be able to impact this really high utilizing and sadly unhealthy group.
So like if they've been there before, like if they're a repeat offender and they have the diagnoses, they have the history, they have the track record in their medical record, and how many times they've been offered it, and how many times, it's like, how do we track whether or not our interventions are serving our population, or whether or not, like, we're kind of not necessarily enabling them, but preventing death for sure, but like how much our dollars, our state funded and federal dollars are serving our community is kind of what I was getting at.
Dane, you had a comment?
Yeah, it's not that hard to collect data. I mean, we use a model with our syringe exchange clients that every client that comes in walks out with naloxone. That's how it is. You know, they're at risk of an overdose. And really, I mean, the collecting of data is not that hard. You know, they're patient with us and that collecting. You know, we're trying to modify our refill, but that's how we know how many overdoses have been reversed. That's how we know how many have been lost. But I think,
does that connect with the big data systems in the hospital though? I think that's where it's not there yet, but that's where it needs to get.
Yeah. I mean, that's what needs to be fixed, but I think you're right, Michael. Why not have some boxes on those forms when they're exiting the hospital? Why are they leaving the hospital without naloxone? There's a pharmacy in the hospital that's money. That should be just ran right through and they should be walking out with naloxone.
Totally agree.
That's my model. I'm just, I'm not meaning to stir things up. I really think naloxone.
Does that mess up primary care, right? Does that mess up substance abuse intervention and mental health access with primary care? Does that? So, I mean, it's these large questions that I don't have answers to that I thought I would just pose to the group.
Well, I think it's a good example, though, of how a council like this informs large system workflows, at least in recommendation, right? Like, we can't force anything, but it's like having subject matter experts come together and identify gaps in the information picture or, in the way that we can assess, where and how we're having impact. I think that would be an example of a great recommendation that we could continue to figure out and formalize. And then I was also going to say, Amanda, we do have data on initiation and engagement, which kind of, in terms of folks falling through the cracks, initiation is when someone gets a diagnosis, like it's a diagnostic event. And then engagement is showing that there were subsequent treatment episodes to follow and wrap around that individual rather than them falling off the grid. That's an example of a data point that wasn't shared here that we have. But there's so many other issues that you mentioned, and I know that it's there's no one answer for it, but I just want to remind the group that this is a group that can make formal recommendations to the system, as a whole, and to this, the service delivery network of, for substance use. So that should be something that is actively done, I think.
Thanks, Julia.
And so Julia and Jeffrey, I'd like to thank both of you for presenting and really just reiterate that this isn't the whole picture, but it's one of those areas where we actually have some data. We've got a couple partners that are willing to share. I think historically we've tried to get some data from our partners at Oregon Health Authority. We'd still like to see a little more there, but there's a lot of other places people access care in our community, whether that be through private insurance, the uninsured, veteran services. So that's a big puzzle. But particularly in the wake of Measure 110, as we all have concerns about, are we still going to be able to engage people? Are we going to lose people in the wake of it? How do we make sure bridges to care are there? Finding some of these places where we can identify, are people still engaging? Do we have the necessary wraparound and engagement strategies? That's going to be important. And so I just want to follow up with that. And as people have ideas, both Jackson Care and All Care have been very, I would say, over the top willing to share information when they can get it and gather it. So that has been a really welcome change for this group. Thanks to both of you. So.
Thanks, Eric. Could I just say one more thing?
Yeah, sure.
I just want to, how can I say this? So I don't want to make any assumptions just because I don't have any, hospital notes sitting in front of me right now. I don't want to make any assumptions that the hospital doesn't have a process and a conversation and an availability of naloxone to folks who are overdosing. I just want to be very clear about that. And what I'm willing to do for this group, if the group feels it would be helpful as part of my check-in next time we meet, is to grab a couple of pieces of those notes, with no identifiers, of course, but to sort of show the group what conversations the hospital has and what the person walks out of there with in regards to naloxone. If you feel that would be helpful, I'd be happy to put that together.
Jeffrey, I think we would really value that.
That'd be great. I know in the past there's been various procedural problems for them, like if their pharmacy was open, was it staffed? It's always the devil's in the details. But I'd love to help with that. Maybe JCC could help with that. I think you guys have some leverage on that. So it'd be great if people want to take a look at that, even just to see where we're starting from.
So Jeff, are you just saying basically to pull a cohort of individuals to examine their hospital experience?
Well, what I would do to just keep it really simple, and again, I wasn't signing JCC up for anything. I was just sort of saying, like, I'm certainly willing to do this for the group, is I would just go into my spreadsheet, look at the past, I don't know, dozen overdose presentations at the hospital. I'd go into the notes, in the hospital notes, and just sort of see at the end of the note what kind of discourse or conversation was had about access to naloxone, and if the note indicates that they're leaving the hospital with naloxone or not. I do recall, I read enough of these notes that I do recall there is information in there, but I don't have it at my fingertips at the moment, so I didn't want to just try to pull it out of a hat. So
I think
that's
yeah.
Go ahead, Julia.
That's a great example of like a more focused data ask for next time. I'd be happy to do this. Are we looking just at first quarter of this year?
It might be good. I think if you and Jeffrey, if there was a way you guys could kind of find out, because the Q1 data will be very clean and you'll be like, this is the actual time period. There shouldn't be lag. And then it will give us a pretty good picture of what our current practice is, I think, too. And so it's
also,
go ahead, Mike.
Also, if you pull Q1, we've already been in the process of doing naloxone for a couple of years. So that would really be a good, more recent data set would be more valuable given the amount of naloxone that's been out there. And one of the things I'd look for if you're doing that chart review would be, what the emission notes said about naloxone, whether it was on board, anything at all to do with it, to see whether or not the concerted effort we've made over the last couple of years has made a difference.
Yeah.
Sure.
No, this is great. That's exciting. And I'll connect more with Jeff online to make sure that we can give a real apples to apples, report out, providing the same exact information. And again, like I love this. I think this is exactly like the way that we wanted this data project to roll, is that, if there were specific asks. So Amanda, you definitely didn't throw a wrench in the process at all, or like open up a can of worms. I think it's, there's ways that we can focus and just pick like this, like one way to look at things and acknowledge that it might not be totally complete. But I think it's a great recommendation. And then Eric, just in terms of like, as we move off this agenda topic, could Jeff and I just give our CCO updates now instead of?
Yes, absolutely. And I'll make a note that you are not accepting Amanda's apology, basically. And you're actually grateful.
Just wondering if when you guys do and analyze the data, if we could get information from Jackson County and Medford and Josephine County arrests with possession. I don't know that it really pertains to treatment, but with the reduced consequences, I'm just wondering like what the correlation between like law enforcement and treatment intervention. I don't know. Is that like super off the board, Eric?
No, in fact, it's funny you should say that. At our local public safety coordinating council meeting earlier this week, we had the Criminal Justice Commission report on Jackson County arrest trends regarding possession of controlled substance and comparing it to the rest of the state. And so I think that there are so many opportunities we have as we look at a health model, but there still are concerns about moving away from the criminal justice model, that the health model may not be fully ready to pick up that piece. but it does give some context.
That's what I'm thinking
So,
too. I mean, I'm just like throwing it out as a seed to sprout.
yeah, we can have some conversation and it provides some context. So I would be happy to invite Kelly Officer to one of our next meetings too. I think Julia, you heard her present, and she's a very good presenter. So she's also, she appreciates questions like Amanda's because she has a curiosity about her data as well. So we can look at that. So thank you, Amanda. Honestly, I know I was giving you a hard time earlier, but that was a really nice conversation that spawned from that. So thank you.
No problem. I'm done. Thanks, guys.
And Julia, if you want to start, we'll go ahead with Jackson Care Connect, and then we'll go to All Care for CCO updates.
Yeah, thank you. So our biggest priority right now is supporting providers with the workforce shortage. It's just kind of an unreal situation right now for providers, and we've Care Oregon set aside $7.5 million to provide, for our statewide network. And in Jackson County, we have supported our anchor SUD and mental health providers thus far with about $1.3 million in extra funding that is going towards creating more parity in wage, helping folks who are on the ground floor and really getting burnout, helping to incentivize them, filling staffing gaps so that we don't have access issues, wait lists. There would have been programs that would have closed down, because of all that. And so we've just really wrapped around providers in supporting them that way, and also looking at other issues that are impacting the workforce. We're looking at how we can support universities as they fill the pipeline of new staff who can help. We're also putting a lot of effort towards the development of gaps in our resources, training, and recruitment for peer specialist positions, certified recovery mentor positions and whatnot. And looking at childcare, how we can support childcare needs that employees have. So we're doing a needs assessment for all the providers on what those childcare needs are in terms of age groups that's been impacted by COVID. And so that's a whole project in and of itself. And then I would say on top of that, we're looking at, right now for CCOs, they're getting information on what their metrics are going to be for 2022. Language access is going to be a metric, an equity metric that is new, and I'm excited about that. That means that all providers and the CCO in particular will be hyper focused on making sure that members who need translation services receive them, and that's not a barrier to receiving care. And then initiation and engagement for substance use treatment, as I described below, will also continue to be a metric, but, among other things. And so, right about now, like the middle of the year is when we really start thinking through work that's been done thus far and how we can create the plan and strategy for next year. And those are really like high level overviews that I had. If anyone had any questions, I can turn it over to Jeff.
Thanks. I actually don't have a whole lot to say. I think, we're hopeful as the COVID restrictions start to peel back a little bit. It'll be interesting to see both anecdotally and in the data how that impacts access to service and engagement for our folks. So we're definitely looking forward to getting back to some in-person contact with our members and providers. And did I have anything else? Oh, I just wanted to mention, I have made several referrals to the Prime Peer program. So I really appreciated Jordan Shin's talk on that program. And, as many of you know, we have several folks who are absolutely resistant to any discussion about treatments or medications or anything. And I'm really looking forward to seeing how the Prime Peer program can slowly but surely wrap themselves around those members and see what kind of success they can have with them that other entities have not. So I just wanted to make mention of that as well. And that's all I have, Eric.
That's a great report out, and certainly for some of those folks for whom there aren't other resources, that is really incredible that they're there for that. So thank you for sharing that, Jeffrey.
Eric, do you want me to share at all about the Crisis Response Project?
Yeah, love to hear about it.
So for those, I don't know if anyone in the room has heard about what came from the listening sessions last year with folks who had lived experience with our crisis, our crisis service, continuum of crisis response, whether that's law enforcement, other first responders, behavioral health. There were listening sessions that came along with last year's all the events that happened within the social justice movement and, the stress with law enforcement and whatnot. And that culminated into a community stakeholder and professional / provider stakeholder group that got together to work on improvements in how we enhance crisis response from a compassionate behavioral health trained lens, to ensure that folks were getting their needs met and not landing, in an inappropriate setting or adding to legal consequences when really they need mental health treatment, et cetera. So this group started forming at the beginning of this year. And it's really been an interesting process because there's no sole funder, there's no sole authority figure. It is a Jackson County, and I'm not talking about the county office. I'm saying it's our regional issue and our shared problem and needs to be a shared solution. And it crosses so many streams of different providers, so many possible funding sources. And it's an opportunity to really take a step towards walking the walk when it comes to equity and inclusion, hearing member voice and member experience, and aligning in a positive way side by side folks who are receiving services with folks who are delivering and providing those services. But that, as you can imagine, is an extremely tense, awkward, challenging, difficult conversation to have because those two worlds they're not similar. And so while there needs to be alignment, the process towards alignment can be tricky and complicated. Ultimately, what we want to have happen with this group of equal community representation and professional / provider representation is we want a plan. We want a plan for how we can take action on improving the system. But, we're still learning how to interact and align and make sure that we're centering voices that have long been marginalized and swept to the side. And I think for some professionals and providers, that's more difficult than for others. And so JCC, All Care, Jackson County Mental Health, Deanne Everson with United Way, many of our providers are really putting forth a lot of effort to make that alignment happen. But I'm really excited about the project, and I hope that the professionals that we've invited to the table will continue to be part of the process, because I think it'll speak volumes for, you can talk the talk as much as you want about how it's important to listen to folks' experiences and to center voices that have been marginalized throughout history, but until you actually do it and go through the difficulty of having those crucial conversations and making space and time for it, then you're not really walking the walk. And so I'm excited for our group and our county to expand participation in that process and to be working on that issue. And
I'm sorry, can you repeat the name of the project?
Yeah, Crisis Expansion Project.
And Is it just for like Medicaid members?
No,
And,
no, it's not.
is it for private insured people too?
Yeah, that's a great question. So everyone's acknowledging that anyone who uses the crisis response system is coming from like who knows what background, right? They may or may not be a JCC member. They may or may not be all care. They could be wealthy, you know, private insurance, you know, they could be Eric Geyer. Eric Geyer could be accessing
mental health or substance use.
mental health, substance use. Yep.
Okay.
It's about the folks who are impacted by our crisis intervention, you know, continuum of care of all the folks who provide crisis intervention services, law enforcement, EMT, mental health response. It's about all of that.
I'd love to hear more about it. Is it new?
Fairly new. It's just this year. It's just this year, stakeholder group, and we have a meeting coming up on the last Tuesday of the month. So I'm going to put my email in the chat, and then folks can email me if they want an invite to that community meeting or just more information. Thanks, Eric.
Thank you for sharing that, Julia. Important work.